Hello and welcome. Today, we're diving into a rare and complex neurological disorder, Alexander disease, with a specific focus on its hearing-related aspects. While primarily known for its impact on the brain, Alexander disease can, in some cases, affect hearing and auditory processing. Let's explore this fascinating and challenging condition together. Alexander disease is primarily a genetic disorder. The most common cause is a spontaneous or de novo mutation in the GFAP gene. This gene provides instructions for making glial fibrillary acidic protein, or GFAP. GFAP is a protein found in glial cells, specifically astrocytes, which are essential for supporting and nourishing neurons in the brain and spinal cord. While most cases arise from new mutations, it's also possible, though less common, to inherit Alexander disease from a parent in an autosomal dominant pattern. The root of Alexander disease lies in the accumulation of abnormal, misfolded GFAP protein within astrocytes. These protein clumps, known as Rosenthal fibers, disrupt the normal function of astrocytes. Astrocytes play a crucial role in maintaining the brain's environment, regulating neurotransmitters, and providing structural support. When they're compromised by Rosenthal fibers, it leads to widespread dysfunction. This dysfunction disrupts myelination, the process of forming a protective sheath around nerve fibers, hindering nerve signal transmission. The specific mechanisms leading to hearing impairment, when it occurs, are still being investigated, but it likely involves damage to auditory pathways in the brainstem or auditory nerve dysfunction. Alexander disease is exceptionally rare. Because most cases result from spontaneous mutations, there is no specific population that is more predisposed. It affects males and females equally. The exact incidence and prevalence are difficult to determine due to the rarity of the disease, but it's estimated to affect only a handful of individuals per million. The signs and symptoms of Alexander disease can vary greatly depending on the age of onset and the severity of the disease. In infantile onset, the most common and severe form, symptoms can include developmental delays, seizures, an enlarged head, macrocephaly, and progressive loss of motor skills. When hearing is affected, symptoms can manifest as hearing loss, difficulty processing auditory information, delayed speech development, or a lack of response to sounds. In later onset forms, symptoms can be more subtle and may include speech difficulties, motor problems, and coordination issues. It's important to note that hearing involvement is not a universal symptom and is more common in some variants than others. Diagnosis of Alexander disease typically involves a combination of clinical evaluation, neuroimaging, and genetic testing. MRI scans of the brain can reveal characteristic abnormalities, such as white matter changes and the presence of Rosenthal fibers. However, a definitive diagnosis is made through genetic testing to identify mutations in the GFAP gene. Audiological testing, including hearing tests and auditory brainstem response (ABR) testing, is crucial to assess the extent of any hearing impairment. The specific features of hearing loss or auditory processing deficits can help to distinguish Alexander disease from other neurological conditions. Alexander disease is generally classified based on the age of onset: infantile, juvenile, and adult. Infantile onset is the most common and severe form, while juvenile and adult onset tend to have slower progression and milder symptoms. The classification is helpful for understanding the likely course of the disease and tailoring management strategies. There aren't formally classified subtypes specifically related to the hearing-related forms. Currently, there is no cure for Alexander disease. Treatment focuses on managing the symptoms and providing supportive care. This may include medications to control seizures, physical therapy to maintain motor function, and speech therapy to address speech and language difficulties. For hearing-related issues, hearing aids, cochlear implants in certain cases, and auditory training may be beneficial. Occupational therapy can also help individuals adapt to daily living challenges. Multidisciplinary approach involving neurologists, audiologists, physical therapists, and other specialists is essential to address the complex needs of individuals with Alexander disease. Because Alexander disease is primarily caused by spontaneous genetic mutations, there are currently no known methods of prevention. Genetic counseling may be helpful for families with a history of Alexander disease, although the risk of recurrence is generally low when the mutation occurs spontaneously. Prenatal testing may be available for families with a known GFAP gene mutation. The prognosis for Alexander disease varies depending on the age of onset and the severity of the disease. Infantile onset Alexander disease typically has the poorest prognosis, with many affected individuals succumbing to the disease in early childhood. Juvenile and adult onset forms tend to have a slower progression and longer survival. Research is ongoing to better understand the disease mechanisms and to develop potential therapies. Gene therapy and drug development targeting GFAP protein aggregation are promising areas of investigation. Further studies are needed to better understand the auditory manifestations of Alexander disease and to develop targeted interventions to improve hearing outcomes.